So good morning, everyone. Let me introduce the 12-month progress of my PhD thesis titled Impact of New Genomic Technologies on Patient Care. My name is Csendes. I'm a medical doctor specialized in clinical genetics, and I work at the Institute of Genomic Medicine and Rare Disorders. My vision is to boost the effective utilization of genomic technologies, and my mission is to recommend, develop, and support educational and financial policies. To achieve that, we need to explore the different aspects of approved treatment in spinal muscular atrophy. Our first project is investigating the functional ability of patients before and after Spinraza treatment in spinal muscular atrophy. Spinal muscular atrophy, SMA, is a progressive hereditary neuromuscular disorder resulting from the loss of the SMN1 gene, which leads to several muscle weakness and atrophy. Without adequate treatment, it can be lethal under age of 2. So no wonder it is the most common genetic cause of infant mortality, with an incidence of approximately 1 in 10,000 live births. Fortunately, within the last few years, 2 disease-modifying therapies, Spinraza and Evrysdi, and 1 gene therapy, Zolgensma, have been approved for use in SMA. Within our initial project, we will exclusively concentrate on Spinraza, as a significant amount of eligible data is only accessible for this medication. Approved in 2016, Spinraza became the first treatment in SMA. Administered via intrathecal injection, it is a lifelong and extremely high-cost therapy. There are 4 types of SMA based on the onset of the disease and the severity of the symptoms. Alternatively, SMA can be divided based on the functional abilities of the patient at their time of their diagnosis, namely non-sitters, sitters, and walkers. Previous meta-analysis used the traditional classification. However, we would apply the aforementioned groups because correlates better with the outcomes to be examined and reflects the variability in therapeutic response in a more efficient way. So our aim is to investigate the effectiveness of Spinraza in patients with SMA with different functional abilities. Which leads to our question, how the functional ability of the patients with SMA influence the effectiveness of Spinraza. To answer our question, we set up a PICO framework. Our population is non-sitter, sitter, and walker patients. Our intervention is after Spinraza treatment. Our comparator is before Spinraza treatment, and we would like to measure effectiveness and safety. Our hypothesis is that the clinical effectiveness of Spinraza significantly depends on the functional ability of the patient with SMA. With our study, we would like to emphasize the importance to classify and treat the patients according to their functional abilities. We conducted our systematic search in 3 databases. Here you can see the finalized search key for that. After the selection process, we ended up 16 eligible full texts. We analyzed all of our planned outcomes, so let me introduce the results of these. On the first forest plot, you can see the 1-year change in motor function based on the Hammersmith Functional Motor Score. This score assesses the patient's ability to perform different activities, total score ranging from 0 to 66, where 66 means that the patient's functional ability resembles that of a healthy person, and 0 indicates poor motor condition or inability to perform any activities. For the statistical analysis, we used mean difference. In the walker subgroup, the mean difference was 2.99, and in the sitter subgroup, the mean difference was 2.57. Although the effect of Spinraza is small, it is clinically relevant for the individual patient. Another noteworthy conclusion is that the functional ability does not impact the drug's effectiveness. Moving on to my next forest plot, you can see the 2-year change based on the same Hammersmith Functional Motor Score. The mean difference in the sitter subgroup was 1.64, which is approximately the same, or a slightly decrease can be observed compared to the 1-year result, which can be expected due to the natural course of the disease. The result is not statistically significant, so we would need more data to support our statement. On the third forest plot, you can see the 1-year change in motor function based on the revised upper limb module. This score assesses the patient's upper limb function, total score ranging from 0 to 37, where 37 means that the patient's upper limb function resembles that of a healthy person, and 0 indicates no upper limb function. For the statistical analysis, we used, once again, mean difference. In the Walker subgroup, the mean difference was 0.33, which is not clinically relevant. And in the sitter subgroup, the mean difference was 1.03, showing a clear tendency for improvement. With additional articles, the mathematical significance may emerge. Although a 1-point change might seem insignificant, for a patient, it means that they are able to raise a cup to their mouth. Without any treatment, the patient condition would deteriorate, so any improvement is considered as a success. Of course, our study has its strength and limitation. One of our strengths is the detailed subgroup analysis regarding the non-sitter, sitter, and walker division. On the other hand, this is our limitation as well, because due to the different classification in previous studies, unfortunately, not all data can be assessed. Based on our results, Spinraza has proven to be efficient in the sitter and walker subgroup, so therefore, clinician can indicate Spinraza therapy for sitter and walker SMA patients. Future studies should consider applying the alternative classification more widely. Here you can see the progress of my first project. We are currently in the home stretch finalizing the manuscript. Moving on to my second project, which is investigating the effect of approved treatments for spinal muscular atrophy on the patient's healthcare needs. Before the era of disease-modifying therapy, best supportive care was the gold standard for spinal muscular atrophy. It is a comprehensive approach that aims to address the various aspects of the condition. The key elements are nutritional and respiratory support, orthopedic care, and rehabilitative services. I already introduced to you the approved treatments, Spinraza, Evrysdi, and Zolgensma. It is important that to these days, treatments must be provided alongside to the best supportive care. Managing the symptoms of SMA often require a large amount of healthcare utilization. The healthcare needs of SMA patients include individualized, precisely designed supportive, rehabilitative, and palliative care, which comes with a substantial cost. There is a limited information of healthcare resources utilization. However, it would be essential for adequately designing public policies and funding decisions. Our aim is to investigate the effect of addition of Spinraza, Evrysdi, and Zolgensma on healthcare needs compared to the best supportive care only. Which leads to our clinical question: how does the addition of Spinraza, Evrysdi, and Zolgensma influence the healthcare needs compared to the best supportive care? We once again set up a PICO framework. We would like to compare best supportive care and each and every approved treatment to best supportive care only, and we would like to measure the healthcare needs of SMA patients. Our hypothesis is that the addition of Spinraza, Evrysdi, and Zolgensma significantly reduce the healthcare needs compared to the best supportive care only. And hopefully, my two projects will contribute to address the different dimension of treatment impact and allow me to finish my presentation with Peter Drucker's words: the best way to predict the future is to create it. Thank you so much for your attention.
Congratulations for the presentation. My question is regarding the first project, that you have a lot of studies, and I wonder if how different is the standard of care in these studies? I mean, beside the gene therapy, like physiotherapy, is it similar in the different studies? You know what I mean? Because what I see in the everyday life, we also treat a lot of patients with SMA, that it's very important that how much additional standard of care they receive, like physiotherapy or not. So how did you find it?
I mean, it needs to be regulated. So as you said, it is important that patients do physiotherapy and so on, but unfortunately it depends on them. So we don't know exactly what they do at home, and but you know, at the hospital we are able to see, but they only do the scoring with and that's all. But so we don't know if they what they do at home.
Okay, so these studies do not focus on the standard of care.
Yes, yeah, unfortunately.
Thank you.
You're welcome.
Any upcoming questions from the audience? Okay, then I have one question. You mentioned that Spinraza is administered intrathecally,
yes.
But I maybe missed it. How often need the patients this intervention?
Yes, so after the loading phase, it is a four-time injection. After the loading phase, every 4 months,
okay,
they receive this medication.
Is there any adverse events during these studies that I mentioned? Because you have shown us the results or the success part, but
yes,
not
fortunately,
much about the safety.
Yes, fortunately, no serious adverse events. Only the consequences of the intrathecal injection itself, so like headache, back pain, nausea, vomiting, but usually that's the main adverse events.